So Neeraj, you will start off, right?
Sir, you're muted.
Sorry. Good evening, everyone. We welcome you all to Ortho TV online. And this is the new series, the Ortho TV Expert series. And today we have a very senior orthopedic and joint replacement surgeon from Mumbai, Dr. Vidyanand Raut. He's done his post-graduation from KEM Hospital, Mumbai. He has completed his Ranawat Fellowship at the Hospital for Special Surgery, New York, and he's practicing since 1999. He has multiple fellowships under his name in joint replacement surgery from India, Australia, and USA. Besides that, he is very famous in Mumbai for doing joint replacements. And I feel that he has done joint replacements for more surgeons than we can count on our fingers. So with this, I hand over to Dr. Vidyanand Rao, who's going to talk on diagnosis of prosthetic joint infection. Over to you, sir.
Thank you, Dr. Neeraj. First of all, I wish to express my heartfelt gratitude to Ortho TV, the entire team of Ortho TV, and in particular to Dr. Neeraj Bijlani for making this happen. And I'm very glad to be part of this. Okay, so shall I share my screen now?
Yes.
Okay.
Yes, go ahead, please.
Okay. All right. Okay. All right. So I'll begin straight away. Prosthetic joint infection, that is a joint infection after a total knee replacement or a total hip replacement, is an extremely traumatizing event for everyone, especially if it's your own case. Today I'm going to focus mainly on hips and knees because that's the common thing that we do in India. But this also includes total shoulder replacements and other joints as well. But we'll focus on the hip and knee aspect of it. Okay, so just to give the things a bit of a perspective, let us see the incidence of infection after a joint replacement surgery. So after primary total hip replacement, the incidence is about 1%. And primary total knee replacement, the incidence is about 1 to 2%. Obviously, in revision surgeries, for obvious reasons, the incidence is much higher, 3 to 4% in hips and 5 to 6% in knees. So what this means is that if I'm talking of a primary total knee replacement, if I do 100 knees, 1 or 2 of them are bound to get infected despite my best efforts. Even if I take the maximum care, even if the antibiotic protocol is perfect, even if the OT setup is good, some of my knees, a minor percentage, 1 or 2%, are going to get infected. And I need to identify those. I need to pick up those in the post-op period so that I can arrest the infection and stop the things from becoming from bad to worse. It must be noted that most of the infections, about 2/3 of the infections, occur in the first 2 years after surgery. Most of them. And if we classify infections based on their chronology of appearance, we can place them into 3 groups: less than 3 months, 3 months to 2 years, and beyond 2 years. It must be noted that in the first 2 groups, that is less than 3 months and 3 months to 2 years, in these 2 groups, the possible origin of the organism is from the operating room itself. What does this mean? It means that patient has gone home after a knee replacement and you are happy. Suture removal done. There is no sign of obvious infection. And he comes back to you after 6 weeks and develops an infection. You cannot blame it on the patient or on some other factors like the infection has come from a urinary infection or a chest infection or something like that. No, you have to assume that the infection came on the day of surgery from the operating room. Most of the times, the possible bacteria are gram-negative bacteria or Staph aureus. That's the most common. Beyond 24 months, it is likely that the infection is a secondary infection through hematogenous CD. That is, it has come from some other part of the body via blood. Okay. We are now going to focus only on the immediate post-op infection. That's less than 3 months and 3 months to 2 years. So we all know the risk factors which can possibly lead to infection. Most important factor is an active ongoing infection at the time of surgery, like a urinary infection, a dental infection, skin lesions, pneumonia. And every surgery, we screen patients to ensure that there is no source of infection ongoing at the time of surgery. But in addition to that, there are several other factors: previous local surgery, immunocompromised patient because of any reason, diabetes, especially poorly controlled diabetes, morbid obesity more than BMI more than 35, malnutrition, HIV positive patients, even rheumatoid arthritis patients are risk factors. Lifestyle problems like smoking, excessive use of alcohol, they are also risk factors. A lengthy surgery extending maybe more than 2 hours is also a risk factor for surgery. And last but not the least, we must take into account suboptimal operation theater environment. So if you don't have a laminar airflow system, or if you don't follow the proper operative protocols, it is likely that the chance of infection is higher. So, as I said, the pathogenesis of infection, most of the times, the offending organism is Staph aureus. Now, one must know what is a biofilm. Biofilm, after a surgery, is the start of the infection. Biofilm is a complex community of microorganisms which are embedded in an extracellular matrix that forms on the surfaces of the implants. And the film is mostly made up of 85% of it is made up of glycocalyx or polysaccharide layer, and the remaining 15% is actually the organisms. So this is something that happens. So at the bottom of the screen, you can see a gray bar which represents the surface of an implant, say a knee replacement implant. So one possible organism comes and sticks to the surface. So it stays there, it's all alone for some time. Then it creates a monolayer, a production of a matrix around it. This matrix sort of gives it a cushion. And within that cushion, it multiplies. So it forms a microcolony. So as you can see here, it forms a microcolony which is protected by that biofilm. And later on, the biofilm will mature, where more and more organisms are created. And then they also secondarily seed. So some of the organisms come out and then they go to other parts of the implant surface. The thing I'm trying to stress upon is that we have to attack a possible infection before the mature biofilm is formed, which occurs maybe 3 months, 3 weeks to 3 months, any time in that period. So if we pick up the infection early, even if the biofilm is in the process of forming, we are able to treat it in a much more effective manner without resorting to a two-stage revision. So we will talk about that in detail. Again, the similar slide, offending organism is Staph aureus or coagulase negative staphylococci. Sometimes it can be polymicrobial also. Okay, so all that pathology, microbiology, all that stuff is okay. I mean, it's okay to present in the slides. But in the OPD, clinically, the question that haunts us is this: is the joint infected? Say, for example, you see this picture. You see this knee, you have done a TKR. Patient has gone home 48 hours after surgery and has come back on the day 6 or day 7 with local warmth, redness, swelling, intense increase in pain, and a low-grade fever. And now you start worrying, is it infected? So definitely the clinical picture will suggest that there is enough reason for you to be worried. You should assume that it could be possibly infected and you should take steps. You should find out and put your mind at rest. So what should you do? Instinctively, what do we do? The first thing that we do is we order a blood test. It's easy. So we do a CBC count. Is the CBC count really relevant? You do a total WBC count and that comes to say 18,500. Does that tell you anything? Yes and no. It tells us that there is an active inflammatory process underway, but it does not tell for sure that there is ongoing infection. In fact, this is a very important paper and it comes straight from the Mecca of infection in orthoplasty. It comes from the Jawad Parvizi group, and they have published it in 2012 in the Journal of Arthroplasty. The bottom line is serum WBC count has no role as a marker for prosthetic joint infection. Obviously, if your WBC count is 25,000 or higher or something, you know that something is going wrong, but you cannot be sure. Okay. So in absence of a serum WBC count or a blood WBC count, what tests do we rely upon? So we rely upon blood tests, synovial fluid test after joint aspiration, and maybe a few imaging studies. We'll see each of them in detail. I hope I'm audible. Is everything going according all right?
Yes, it's going on.
Yeah, okay, fine.
You can hear everything.
Thank you. So next slide. So first, let us consider the blood tests. The commonest blood tests that we do are ESR and CRP. And the importance of ESR and CRP cannot be undervalued. Basically, ESR will come back to normal 3 months after surgery. CRP will come back to normal 3 weeks after surgery. So beyond 3 months, if they are still high, then there is a high chance that the joint is infected. Apart from ESR and CRP, another important marker is serum interleukin 6. And that comes back to normal within 3 days after surgery. So if that is higher, then there is a good chance that it is infected. Its sensitivity is 100%. Other markers are serum procalcitonin and D-dimer, but we don't routinely do this. What we routinely do is ESR and CRP. So as I said before, within 3 months after surgery, they will still be less, especially the ESR will still be high. But after 3 months, if the ESR is more than 30 and if the CRP is more than 10, then there is a 96% probability that your joint is infected. Okay, and this is relevant after 3 months after surgery. But if it's less than that, then you have to rely more on your clinical judgment as well as on the synovial fluid aspiration tests. So that's easy. If you are able to get 5 to 6 ml of joint fluid, the synovial fluid, then that will give you a wealth of information about the possibility of infection. When it comes to the knee, it's easy. You yourself can do an aspiration and take out the joint fluid. 5-6 ml is easily available. It's difficult in the hips. So when you are thinking of infected hips, you should get the help of your radiology colleagues, and under ultrasound or CT guidance, you can have the joint aspirated and then subject it to all these tests. So what are the tests that we can do on synovial fluid? First of all, synovial WBC count. Synovial WBC more than 3000 indicates infection with an 80% probability. Synovial CRP more than 6.9 is highly suggestive of infection. Neutrophil to lymphocyte ratio, or NLR, more than 3 also indicates infection. Then there is a test called alpha defensin, which is not easily available in India, and it's very costly. The international cost is around $400, but it's good in the sense that it is 100% sensitive and 98% specific for infection. Unfortunately, we don't do it in India because it's not available anymore. Then we can do a gram staining for bacteria, and most importantly, we can subject that synovial fluid to culture and sensitivity. Another test which needs to be mentioned is leukocyte esterase. So this is a very simple test. It's as you can see at the bottom of the screen, it's like a hemoglucose. It's a dipstick test. You can dip that stick directly into the synovial fluid, and if the reading shows plus or +2 or +3, then we can have an idea of infection. More than +2 is 81% sensitive and 100% specific for infection. And the test is very easy to do. Another thing which I skipped was synovial calprotectin. That also is very specific and sensitive for infection. But we don't do all of these tests. So what we do routinely do are synovial WBC. As I said, WBC count more than 3,000 indicates infection. Second, synovial CRP count more than 6.9 indicates infection. Third, we do a culture and sensitivity test. That's important. And fourth, leukocyte esterase test, because it is easy. Even if we do just these 4 tests, we can be fairly certain of whether there is or there is no infection. Apart from the synovial test, now we come to the imaging studies. Really speaking, X-ray and other imaging studies, they have no role in actually helping us to diagnose if your joint is infected. What will the X-ray show? It will show some periosteal reaction. It will show patches of osteolysis, bone resorption, implant loosening. But all these will be seen at a later stage of infection, when it is clinically evident and there are other factors like maybe a discharging sinus. So the infection is evident anyway. So you don't need to have the X-ray for that. You need the X-ray for planning of your treatment. So X-ray, no role in diagnosing infection. And the same thing is true for bone scan, PET scan, and MRI. They are very sensitive, but not very specific. So they will show positive uptake in the presence of inflammation, in the presence of some vascular thing, in the presence of tumor, and also in the presence of infection, but we cannot differentiate. So we should not rely on any imaging study when it comes to diagnosis of infection. So to summarize, your clinical judgment is important. That's number 1. Number 2 is ESR-CRP, the basic blood tests. And number 3, joint aspiration. Again, doing a CBC, synovial CBC, synovial CRP, and a culture sensitivity. Based on all of these, we can now come to a conclusion. But that brings us back to the original question. We have all the tests with us. We have all the reports in front of us. Some reports are definitely positive for infection. Some are okay, gray zone. And some indicate that there is no infection. So again, we are back to the same old confusion. Is it infected? Fortunately, we have the MSIS criteria, or the Musculoskeletal Infection Society criteria. I think they were given out in 2013 or something. Yeah, I remember 13. So what are these criteria? So they have given major criteria and minor criteria. Major criteria, if any one of 2 major criteria are present, then there is definitely infection in your prosthetic joint. But if none of the 2 major criteria are present, then we resort to minor criteria. And we need to have any 3 out of possible 5 minor criteria to be present. So let's see all these criteria in detail. First, the major criteria. So major criteria number 1 is a positive sinus tract which is visible and which is seen to be communicating with the prosthesis. If that is there, as you see in this picture, then you don't need to consider anything else. Your joint is infected, 100%. The other criterion is a pathogen which is isolated by culture from 2 separate synovial aspirations from the affected prosthetic joint. So if any one of these 2 criteria is present, then you are 100% certain that there is infection. If none of them are present, then we will go to the minor criteria. Maybe it's difficult to remember these minor criteria, but it's very easy to have this slide ready. We can have a picture of this on our desktop also. So the minor criteria are elevated ESR more than 30 and simultaneously elevated CRP more than 10. That's number 1. Number 2 is synovial WBC count more than 3,000 or a positive leukocyte esterase test. Number 3 is a elevated PMN percentage more than 80. Number 4 is isolation of a pathogen in only one culture of the joint fluid. And number 5 is histological criterion, greater than 5 neutrophils seen per high power field in 5 different high power fields observed from the periprosthetic tissue. Okay, so out of these 1, 2, 3, 4, 5, any three are present, then also you can say that your joint is infected. In 2018, there was an international consensus meeting, or ICM, and this was in Philadelphia. So it's called ICM Philly. And joint replacement societies from all over the world represented that meeting. Our own Indian Society of Hip and Knee Surgeons was also represented. And a consensus was drawn how to diagnose infection. So basically the same MSIS criteria which I mentioned in the previous slides, they are all of them are adopted, but they have also added D-dimer. They have also added alpha depensin because that is available out of India. And they have given a quantitative score. So based on that score, we can judge and we can decide if the joint is infected or not infected. Somehow I find this a bit confusing. And they have given it in the form of a algorithm, which is further confusing. I mean, one look at it, I am confused. What happens when? So I find it handy to use the major criteria and the minor criteria. It's very simple. Major criteria, either a sinus tract or isolation of the pathogen, and the minor criteria as we discussed all of this. So mainly the minor criteria being ESR, CRP, synovial CBC count, and the histological criteria. So based on this, we can come to a fair conclusion if our joint is infected or not. I say fair conclusion. Why? Because there is no single test for finding if the joint is 100% infected or 100% not infected. We cannot make that distinction. So based on our clinical judgment and all the tests, then we come to a decision. This is probably infected. Why it is important to come to that conclusion quickly is you can be in a window where you can deal with the infection easily in the form of a DARE procedure. So briefly, we are not covering the treatment part of the infection here, but I'll be brief about it. DARE, it's DAIR, debridement, antibiotic, and implant retention. It means that, say, for example, a practical picture. 3 weeks after surgery, patient has come back to you and shows clinically some signs of infection. You do all these tests, and based on these tests, now you are more certain that probably this is infected. You preemptively prevent the infection from progressing further. You counsel the patient properly that we have to take steps now, today, to curtail this infection. So take the patient into the OT, open up the wound under proper precautions, as if you are doing a primary surgery. Open the wound, give a thorough wash, do a thorough debridement, and change the part of the implant which can be easily changed. In the case of a knee, it is the poly. Removing the poly will allow you to approach the back of the knee and do a debridement from that area, take histopathological samples also from that area, and then you change it with a new poly. Okay, but don't change the implants which you have cemented. The femoral component, tibial component, they remain in place. Similarly, in the hip, in the THR, you can change the 22 mm, or sorry, 28 mm or 32 mm head, whichever you have used. That's the only thing that you can change. You can also change the poly liner. But the implant which you have cemented or you have affixed to the bone with the help of a porous coating, that stays in place. And with thorough debridement and a proper antibiotic protocol, you will be able to control that infection easily. The success rate of a properly done DARE procedure is almost 100%. If you miss the train and if you don't do the DARE procedure because you are not sure of the infection or because you don't take the decision quickly enough, then you basically go into a situation where you are forced to deal with the infection head on with the help of a 2-stage revision. In India, we don't do 1-stage revision, but 2-stage revision, but it's a very costly and a long drawn process, and you have to take the patient into your confidence. So the take home message from this talk is that identify the infection early and take steps immediately to prevent the infection from spreading further. Thank you very much.
Yeah, you can stop the screen share. Thank you very much, Dr. Vidyanand Raut, for comprehensive coverage of the diagnosis. We have some questions from our Ortho TV viewers, so I'll be putting it forward to you.
Sure.
The first question is, you are talking about biofilm. So is there any technology yet which basically any blood test or Mars MRI helps in diagnosing infection before the biofilm is formed? Do you do Mars MRI when in doubt?
No, see, when we have done a recent joint replacement surgery, we don't subject the patient to an MRI because we don't want the implant to become loose because of the MRI. The implant has not yet got a hold onto the bone. So MRI at that early stage anyway is dangerous.
Recently, I have been to two Asia Pacific Arthroplasty Society event
Yeah.
meetings, and there was a lot of discussion on biofire.
Yeah.
Yeah, which is a new investigation which helps us in quick diagnosis. Basically, what we need to do is DIR for those type of middle cases where we are not sure whether it is an infection.
Yeah.
So, have you ever used it? Have you got any experience yet?
No, personally, I have never used biofire, but I think it's very promising. Yeah, as you said.
And you were talking about we can aspirate and CT scan or USG guided, we can tell the radiologist. But I have always felt that even if I have gone there to aspirate myself, maintaining the same level of asepsis in the CT scan department of sonography, it's almost impossible. It is very, very difficult. And
Yes.
then sometimes when we get these cultures which are staph epidermidis positive, then it becomes a very problem whether it is infected, not infected. So
Or
that is
if it's a
like a
contaminated
dilemma.
sample. So yeah, that's the problem that occurs, especially in the hips. In the knees, we do everything ourselves in the OT. So one point I will add, whenever you are doing an aspiration, treat it as if you are doing a surgery. Take the patient not in your casualty, not in a side room. Take the patient into the OT and under sterile precautions, aspirate the knee. And for the hip, if you can obviously see that there is some synovitis there, then you can attempt to do an aspiration yourselves. But otherwise, you are placed in a situation where it's a dry tap and it's difficult to tell the patient कि कुछ नहीं निकला वहां से. So maybe for hips, it's a good idea to get the help of your radiologist.
So I wanted to ask you this early, you were talking about when in the first slide you said that it is basically 1 to 2 years. So what about late infection? Like, have you seen infection which has happened after 3 years, 4 years? And
Yes.
what are the most probable cause? Does it come from the blood? People say that dental caries say the infection can spread, or actually it was inherently there, but at that time the patient's immunity was strong, and then the patient's immunity became weak and the chronic infection came out.
We can never know for sure, but we can assume that since the joint was not infected for the first 2 years, probably nothing wrong occurred in the operation theater. And the infection has come, the source of infection has come later on, it was introduced into the body. And coupled with factors like malnutrition or immunocompromise, somehow it has traveled through the blood to the joint. So the possible sources again can be dental caries, urinary infection, all the common things, pneumonia.
So as you said that patient's immunity plays a very important role in infection and prosthetics.
Yes.
So when we are doing the surgery, first time, primary TKR or primary THR, as these are very routine surgeries and maybe the patient can wait up to a month or so. So what are the precautions besides the regular diabetes control, urine infection, dental treatment? Is there anything else which we can do, or maybe we can check and correct that? Maybe like giving some supplements, protein supplements, some vitamin D correction. Do you do all these routinely?
As soon as the patient is ready for surgery, most of the times in our settings, frankly speaking, he comes up on table within 1 or 2 weeks. Okay. So for high volume surgeons, when they have a 3 month or 4 month waiting list, they can afford to do this. They can tell the patient to take these supplements and build up their immune status. But frankly, in most people, for most surgeons, the reality is that we don't have time to build up the immunity. We have to accept whatever it is.
What about post-operative? Like post-operative, are you giving any supplements?
Yeah, so post-operative protein supplements are a must. Okay, if the patient is a non-vegetarian, it's quite easy. But for vegetarian patients, I would give them additional protein supplements where there are several over-the-counter remedies also available. And proper diet, attention to diet is important. Hydration is important.
So there was this case in my practice where you get these superficial, doubtful infections. They are very superficial. there is not a proper sinus, but at the same time, you feel that there is a lot of skin necrosis. Sometimes the fat starts oozing after 15 days. We don't come to know whether it is actually fat or whether it
Yeah.
is actually pus. It is very difficult,
Yeah.
especially after 15 days. So will you wait? Will you aspirate? How will you judge that this
Yeah,
patient is
yeah,
infected
yeah.
or not infected
So,
clinically?
so very good point. Thank you for bringing that up. And another thing which complicates the issue is the patient is on blood thinner. Either he is on blood thinner from before, or you have started it as part of your VTE prophylaxis. So you sometimes get on day 6, day 7, day 10, a leaky wound. So there is some brownish or orangish cleared discharge. It's not actually pus. So then you are in doubt whether it is because of the blood thinner or whether there is infection. But your sense of caution will tell you that you need to investigate him properly, at least do a ESR CRP, if not in aspiration, and check. If things seem out of the ordinary, then you do an aspiration and check. Okay. But if the patient is on blood thinner, the first thing I would do is I would stop the blood thinner for 2 days, do a dressing, call the patient back in 2 days' time, and that gives me a time. If it was because of the blood thinner, it will stop in 2 days. Okay. Now it could be, as you said, it could be a stitch abscess. Sometimes we use staples, and the staples are close together. Sometimes it causes skin necrosis, and especially if the patient has a layer of adipose tissue beneath your staples, then that undergoes liquefaction, and that also mimics infection. So again, you do a dressing, press and clear out whatever fluid has been collected, and observe for 2 days. If it does not come back, then you should not worry. At the same time, again, this improves an important point. Your closure should be very robust. After a knee replacement surgery, you should have a proper number two, not number one or 10, number two closure with Vicryl. My preference is Vicryl of the entire extensor retinaculum. So what this does is that even if there is a superficial infection, a stitch abscess or something like that, it will not spread deeper. You can just do a dressing and keep a watch, and it will settle down.
So there are two, three things. Basically, right now, nowadays, many people have given up the tourniquet. Do you still use the tourniquet for TKR?
Yeah, my protocol is I always raise the tourniquet and release it after cementing. So before
Okay.
closure, I want to make certain that there are no bleeders which will cause a hematoma.
Usage of drains in TKR and THR?
Routinely, I never use a drain. Routinely, except in maybe two high BMI patients, I would use a drain. Most of the times, no.
I'll tell you my experience, though I don't do many THR, but bipolars. So in TKRs, definitely we stopped using the drain long back. But in THRs, I'm still not comfortable using not using the drain. I do use the drain. Sometimes, in fact, if the patient is too obese, I'll use the drain has two pipes. So
Yeah.
one will be deep, one will be
Superficial and
superficial.
deep. Yeah.
Yes, and I will remove it after 24 to 40 hours, depending on how much the drain is coming. Because whenever I have not used the drain, I feel that the soakage is just there too much, and I have been given a call at the night or the next day morning that it is soakage, and then I'm scared whether it is infection, whether it is just soakage
Right.
because of
Yeah,
the
yeah, yeah.
drain.
So there
Yeah.
is no downside of using the drain. If you're removing it in 24 to 36 hours, absolutely fine. It's not a problem. Okay. But there are two schools of thought. Many people have given up on the drain, but there are many people who still continue using the drain. The jury is still out.
Hmm. And when do you mobilize the patient? Does
Immediately,
that
next day, next morning
next
after surgery.
next day? Okay, so after almost 12 to 24 hours, not before that, not in the same day.
No, not on the same evening. Even if I operated early in the morning,
Hmm.
if I take an evening round at say 7 p.m. and if the patient seems to be fine, I am tempted to make him stand with the help of a walker. But
Hmm.
then I say to myself, what is the hurry? Let him rest for one day. Let
Hmm.
all the hemodynamic parameters and everything come back to normal. His pain level is already under control with various pain controlling measures. And the next morning, we have already primed the patient that next morning आपको खड़ा होके चलने का है. So that's how we do it. This is true for hips as well as knees.
Hmm. So there is this one very important aspect which I have seen. Now the patient is come to you, you have operated after say not 2 weeks, wound is fine, everything is fine. but he comes to you after 1 month and suddenly there is one vicryl which is being seen and there is some stitch abscess is seen. And otherwise, the patient is completely fine. There is no other complaint. He just comes to you with this. Or maybe he sends you a photograph first, then you get scared and then you have to immediately call him.
Yeah.
So what will you do in that situation? What parameters will you check clinically to know whether basically this patient is going towards infection or is not, is just a stitch abscess?
Yeah, most of the time a retained vicryl which is poking out of the skin, and it is usually it is seen at the proximal end, not the distal end. So most of the times it is nothing, it is not a cause for worry. We just do a limited dissection there with the help of a small artery forceps, pick up the suture material and snip it out. Okay, and keep a dressing for a few days, 3 days or something. It will heal on its own. That's not infection. Okay, because I mean, all the other parameters for a possible infection are not there. The wound is not red. The patient has not developed sudden onset pain or fever or redness.
What I have seen in my practice, though it was not a joint replacement, there was one bilateral TKR which of mine was got infected, but basically we could immediately take her in the OT, give her a good wash, and I could salvage it.
Yes.
Patient survived. Patient I think is still surviving. They stopped following up with me after 5 years, but the knee was still doing good after 15 years. So one thing which I noticed as my career advanced and basically as my practice advanced, that the patient who has got infection will have a lot of pain after the dressing also. And I feel the patient who does not have infection, once you have relieved him of the hematoma, his pain will reduce like anything. What is your take on it? Is it like that? That is what I have observed, that immediately after the dressing, I used to get a call, the patient is having severe pain. I used to feel now that this has got infected.
Presence of unexplained pain is a definite red flag when it comes to thinking of infection. So you are absolutely right. I agree with you. Regarding the hematoma, as soon as the hematoma is drained, if there is a hematoma, if I have not used the drain post-operative, this has happened with me once or twice in TKRs. I was called upon, patient has come back on day 4 or day 5 with a very tense swelling. And then there is obviously a hematoma. And 2 times in my career, I had to open up the wound, give a wash. It's a very quick procedure. This is not there. This is just evacuation of the hematoma. And once the hematoma was evacuated, the capsular tension decreased and the patient was fine.
After that, usually the pain completely reduces. After this procedure,
indeed, in both cases. Yeah.
Versus infection, the pain does not reduce.
No, so then that's why. If it's painful, then again, that is a red flag for a possible infection.
Will you put a drain after you do give a wash in such a case?
After I put a wash, then all the no holds barred. We put a drain maybe in 2 layers, and we keep the drain, in fact, for a longer period. For whenever I was using drains, I used to keep them till next day morning. But if I'm using the drain now as part of a day or as part of a wash, then I would keep them for at least 36 hours.
Okay. I don't remember you talking about antibiotics. So what is your post-operative antibiotic protocol, pre and post?
Okay. So starting antibiotics too early before the surgery has absolutely no meaning. Excuse me. So whenever the patient is admitted the day after the day before the surgery, we get a call from the RMO, sir, shall we start the antibiotic? And giving antibiotic 1 day before the surgery is like opening your umbrella when there is no rain. Absolutely no need for the antibiotic before that. So when should we give the first dose of the antibiotic? So we should know the pharmacokinetics of any antibiotic. Most of the times we use 2nd generation cephalosporin. My preference is cefuroxime. So the pharmacokinetics are such that within IV infusion, in 10 minutes, you get peak plasma concentration. Okay, in 10 minutes. And also there is a peak concentration in the operative tissue as well as in the plasma. So the ideal time to give antibiotic would be about 20 minutes before your skin incision. So I instruct my anesthetists, as soon as the spinal anesthesia is given, the first dose of antibiotic should be given. And usually the surgery is over in less than 2 hours, even for bilaterals. So one antibiotic to be given immediately after surgery in the recovery room. And thereafter, I give the antibiotics for a total period of 24 hours after surgery. And there I stop it. I would...
3 doses total.
3 or 4 doses.
4 doses. And after that, no oral antibiotics.
I would give sometimes oral antibiotics for 4 to 5 days. But if I am feeling very confident, then I would forego the oral antibiotics. But if the patient is, if it's a bilateral surgery, if the patient is diabetic, if the patient is even slightly obese, then I would add oral antibiotics for 5 days.
When and how frequently do you do the dressings?
Before discharge at 48 hours, a single dressing has to be done by a senior RMO or someone. Or if I happen to be in the hospital at that time, I check the wound myself. And that's it. After that dressing, directly to be opened at the time of suture removal 2 weeks down the line.
Okay. I think that's all for today. Thank you very much, Dr. Vidyanand Raut. It was great speaking to you. It was a very great and comprehensive coverage of the diagnosis of prosthetic joint infection. Maybe in the next session, we can cover 2, 3 more sessions.
Yes,
The postgraduate students of Ortho TV would like to listen to your basics of conducting a THR and TKR.
absolutely.
Okay, so maybe we'll see you again. We'll call you again in 1 or 2 months. Thank you very much. And thank you, viewers, for tonight. That's all. Good night. Bye bye.
Thank you. Thank you, Dr. Neeraj. Thank you, the entire Ortho TV team. And thank you for all the viewers who have been listening to it. Thank you.
Poonam, please stop.